Part two. Sorry about that. So there's actually going to be two parts of the video. Let's pick up again on page 662 talking about the pancreas. As we mentioned before, the pancreas is both exocrine and endocrine function. Exocrine function actually involves a duct, and as you can kind of see here, the duct is actually where pancreatic enzymes get put into the small intestine, so the duodenum or duodenum, for helping with digestion. The endocrine gland proportion is actually what produces insulin and glucagon, which we'll talk about. They're kind of like identical twins that act opposite. So the islets of Langerhans, you have alpha and beta cells. The beta cells secrete insulin. Remember we talked about insulin is needed, for example, with diabetics, to get blood sugar into the cells. Glucagon is actually the opposite. Glucagon is kind of like I said, the twin that does the opposite of insulin. Glucagon actually gets secreted when you're trying to increase glucose levels. You can also see they also talk about protein synthesis. Insulin increases protein synthesis and glucagon decreases protein synthesis. I'm still on page 662. The pineal gland. The pineal gland is really tiny. It actually is a small pea-like. You can kind of see where it's in the back, and it actually is stimulated by a lack of light. So it produces a hormone called melatonin. Melatonin, unfortunately, is also sold in health food stores and even sometimes grocery stores to help people with sleeping. But as you can see here, melatonin is a hormone that's secreted by the pineal gland. Well, sometimes they call it pineal body, as you see in your slide. And it's really important, though, to regulate your circadian rhythms. So your circadian rhythms are basically how the fluctuations in your hormone levels. So in other words, your cortisol levels should be really high during the day, but not at night, so then you can sleep at night. And your melatonin levels should help you to sleep. So your circadian rhythms are all about maintaining proper hormone levels during the proper time of the day. So let's continue. The thymus gland. The thymus gland is actually located, and I'm still on page 663. The thymus gland is located right above the heart, and it's really big when you're a child. It produces thymosin. It helps with with your immune system function. So for some reason, as an adult, it starts to shrink, and nobody can really figure that out. It actually produces T cells, and so gonads are really important, whether you're talking about ovaries. Ovaries are really important to produce estrogen or progesterone. So even if you had a woman who had a hysterectomy, they try to leave her ovaries so that she'll be able to produce enough estrogen and progesterone to still be able to be functional, where she'll still have, it's cardioprotective for estrogen, bone protective. So your ovaries are really important. And then also testicles or testes are really important to produce testosterone. Remember, testosterone is what creates those male-looking features. The stomach also produces a hormone called gastrin. It produces other hormones as well. So, as I said, when you have stress can be produced by physical factors. For example, maybe pants on too tight. I'm just kidding. So maybe if you have an issue where maybe you feel like you are running a race and you get kind of frustrated about it. Psychological factors. Once again, the biggest thing is students. Right? So as students, you feel stressed about maybe a test or your homework assignment. Also, sometimes even just positive stimuli. Sometimes people can just become stressed and produce too much cortisol. So remember, as you produce cortisol, you become stressed. Your heart rate is going to increase, your respirations, your blood pressure, glucose is going to go up, right? And then also, like I said, it's kind of that increase in cortisol. And so I'm still looking on page 663, and I'm getting ready to go over to page 664. So this is actually when we're going to start talking about the pathophysiology, or the actual cases that you would want to think about when analyzing patients. So everything before this should have been kind of a review for you. Acromegaly. Acromegaly is kind of interesting. And so you see the case here. This actually was a very feminine-looking woman beforehand. So yes, that is a woman. But because she has acromegaly, she produces too much growth hormone. Remember, growth hormone actually gets secreted from the anti-pituitary or anterior pituitary. When you produce too much growth hormone after puberty, right, you'll see where there's an over-exaggeration in her jawline, over-exaggeration in her hands. So she may or may not have grown taller, but based on her age. It depends on whether those epithelial plates have fused, but definitely you can see the jawline, the over-articulation of the hands. So usually the hands, feet, and also the jawline. Where bones don't typically fuse, you would actually see an increase in the thickening of those bones. But you worry about also these patients having an increase in the size of their heart. So they would have a tendency to die from a cardiac issue, potentially also respiratory. Addison's disease is also interesting. I think it was President Kennedy, so John F. Kennedy, what actually had Addison's disease. So Addison's disease has to do with the adrenal gland and the fact that it's not producing enough corticosteroids, for example, cortisol. When that happens, you'll have a person who has issues with their blood sugar, they have issues with their blood pressure as well. So there's a good picture on page 664. We don't really know the cause, but all this patient needs is a shot of cortisol or corticosteroids. So you'll find they have a lot of weight loss as well, some muscle pain. Sometimes they become very dehydrated, and sometimes they have some nausea and vomiting. So like I said, the treatment is really easy, corticosteroids. Then you have a Cushing's patient. So Cushing's is kind of the opposite of Addison's disease. Instead of having too little corticosteroids, you have too much corticosteroids. You can kind of see with this patient, they have this moon face. If she turned around, she might have this buffalo hump or this fatty tissue right around her cervical region. You get this kind of abdominal obesity. And then they often have, particularly a woman, would have an issue with her menstrual cycle, probably maybe too heavy. She'd also have too heavy or lack of a menstrual cycle. She'd probably also have, he or she would probably also have, for example, high glucose levels and a lot of muscle aches. So the treatment for this is to determine where is this extra cortisol coming from. Is the patient taking too many corticosteroids, or do they have an adrenal tumor? So if it's an adrenal tumor in the adrenal gland, then they would try to see if they can actually get rid of the tumor, or slowly take them off of steroids. You can't just abruptly take a patient off of steroids. Diabetes insipidus, remember we talked about that right at the beginning. Diabetes insipidus is also on page 665. Diabetes insipidus has nothing to do with blood sugar, has nothing to do with your carbohydrate metabolism. It only has to do with ADH. That's always a test question I'm going to ask you. So remember, ADH is actually made by the hypothalamus, but it is secreted by the posterior pituitary. So when patients have not enough ADH, they actually don't reabsorb water very well. So you have a tendency to have a patient who has diabetes insipidus who's always urinating, or polyuria. Right? So they sometimes will also have a lot of muscle cramps, and sometimes because of the fact that they're becoming dehydrated, they have electrolyte imbalances, and then that can lead to cardiac arrhythmias. So with this patient, ADH is all they need. So they need what they call, sometimes it's a drug called vasopressin. Diabetes mellitus. I know we've talked about this at the wazoo, but you'll see a lot of patients who are diabetic. Remember, diabetes mellitus has to do with the fact with your blood sugar levels. And there's type 1, type 2, and gestational. And that's also still on page 665. So with type 1, you have people who are considered to be insulin dependent. So typically it's diagnosed during childhood, but you can also have people who are diagnosed in adulthood, usually before the age of 30. Type 2 is non-insulin dependent. They still have blood sugar issues, but this is a patient who wouldn't need insulin, but maybe just needs to change their diet, or maybe have something like metformin, aka glucophage. Gestational diabetes only occurs during pregnancy and usually is temporary, so they still have blood sugar issues due to their pregnancy. Dwarfism. Dwarfism has to do with the fact that a patient doesn't get enough growth hormones, as you can see during childhood. Maybe due to the fact that sometimes it is a genetic component to it, but often it's just a pituitary gland issue. And so, as you can see, typically their torsos are normal, but it's the arms and legs or the limbs that are usually shorter. Gigantism is also the opposite of dwarfism. Gigantism, as you can see, this really tall gentleman here, very tall, slender. Sometimes, if you look, this is also on page 665, people have a tendency to have delayed sexual maturity, right? And then sometimes thick facial bones. But what you'll notice is they're very, very tall. That's kind of the hallmark that you'll see, very tall limbs. The one thing you do worry about is trying to figure out if this is a tumor or if the patient has just produced too much growth hormone. If it's a tumor, they may actually try to, like a pituitary gland tumor, remember because it's made in the anterior pituitary, they may actually try to do surgery if it's operable. So in other words, if they're able to operate on it. Goiters are found, and that's the next thing you can kind of see at the bottom of page 665. Goiters are found, you can see that's a basically enlargement of the thyroid gland. There is found in someone who has hypothyroidism or hyperthyroidism. It has to do with iodine typically in the diet, but it can also be caused by other issues. Graves' disease, as you can see, this is the exophthalmos, or aka bug eyes. This is really kind of a hallmark of hypothyroidism. Hypothyroidism is also discussed on page 666. And so a patient who has hypothyroidism may have the eyes that poke out a little bit, the exophthalmos. They may have insomnia. They may have a lot of weight loss. They may have muscle weakness. They may have a really increased appetite, may have diarrhea. This is the person who's always anxious. They can't sit still. They're kind of the type A's, right? And they may have tachycardia or palpitations as well. So this patient, we really need to figure out particularly with like Graves' disease, if it's just hyperthyroidism. Graves' disease is the most extreme form of hyperthyroidism, so you don't have to be at Graves' disease yet. We consider Graves' disease to be autoimmune. And so with that, you really have to determine if they're going to remove the thyroid or they're going to radioactively kill the thyroid, and then that patient would be on thyroid medications for the rest of their lives. Cretinism, I hate that term, but it's the term used to describe when babies don't have enough don't have enough thyroid hormones, and they have a severe form of hypothyroidism. And so with that, cretinism can lead to stunted growth. It can lead to mental retardation. They have a low body temperature. They have poor reflexes. This is something that really would have to be addressed because otherwise the child may not develop correctly. Mixed edema is the most severe form of hypothyroidism. So the typical hypothyroidic patient will always be cold, will have hair loss and thin, nails that are very brittle. They'll have constipation. Sometimes they have depression. A lot of times they're cold all the time. So it's almost like they turned everything down and everything kind of goes in a very slow motion process. So mixed edema is the most severe form of that. It could be something that may be congenital, but once again, you'd have the person who, particularly also with the woman, low blood pressure, low heart rate, so bradycardia, and then a lot of weight gain, puffy feet, puffy hands. You'd have someone who, if they were a woman, had abnormal menstrual cycles. So remember, the most important thing is, it's not stress that kills you, it's your reaction to it. So this is the end of the lecture. There's also going to be another PowerPoint from another book that may also help you if you had any issues with the textbook. You're not required to look at that one, but I strongly suggested you look at it because it'll also help you to clarify any types of pathologies that you may have not thoroughly understand from the chapter. Okay, well, thank you for listening, and I will see you on Wednesday, April the 29th.